old case of white intumescent cataract with anterior chamber depth of 2.4 mm. I tried to carve out the rexes and there was an Argentinian flag sign. What do we do now? I inflated the chamber with viscoelastics and regularized the capsule rexes. I preferred chop technique with first chop done without much separational forces and not 90 degrees to the tear. At the same time, my focus was on trypan blue stained anterior capsular tear. It was fluttering and everted. Nuclear emulsification was done at iris plane. Fluttering flap meant 100% flap tear had not extended beyond equator. That gave me full confidence to continue the surgery with safe phacoemulsification technique. Had the flap become inverted and non-fluttering, it would have meant that the tear had become wraparound post-equatorial tear. There were minimal separational forces applied again. I also avoided sudden collapse or deepening of the chamber. My phaco parameters were on the lower side. Flap was still everted and fluttered. The initiation of rotational forces were minimal and were done keeping in mind that the rotational force did not put stress to the extended flap. Last nuclear piece was eaten and nuclear emulsification was completed with the continuous will on the everted nature of the flap. Cortical aspiration was done with lower vacuum, with the fluttering of flap tear kept in my visual horizon. I confidently implanted the IOL in the bag as I knew the posterior capsule was intact because of the flap motility sign in my armamentarium. Flap motility For better explanation, these animations show that the pre-equatorial tear is everted and freely fluttering in nature. Hypothesis for fluttering flap is that the end point of the extension of the flap functions as the pivotal point for the flap. The flap, being short, is responsive to the fluid dynamics of the interior chamber and thus flutters freely. But once the pre-equatorial flap extends beyond equator, the flap becomes inverted and stops fluttering. As there is a breach in the barrier in the event of posterior extension of the extended anterior capsular tear, there is pulling down of the anterior capsular tear. The pulling down is because of the combination of the higher pressure of anterior segment, increased capsular bag volume, and the negative pressure of the posterior segment that pulls down the bag complex and makes the flap lie flat and eventually become inverted and non-responsive to fluid.
So this flap motility as a sign of posterior capsular rupture is a published sign now, and it had won numerous awards worldwide. Coming to the capsular access challenges in zonulopathy. So if you see in this first video, so there's difficulty in initiation, there's wrinkling because of the mobility of the bag with tear forces. Often you see in the second video a halo sign or a focal depression. So preoperatively, whenever you find there's a difference between the ACT in both the eyes, it should always give you a clue that there's something wrong with the zonules. So a few strategies in weak zonulopathy for rexes is that you can always use bimanual forceps, bimanual rexes. What you do is the second forceps, it holds the capsule, acts as artificial zonules, provides counter traction, and thereby it helps in completing the rexes. If you see in this animation, the second forceps is acting as a counter traction for the completion of the rexes. Similarly, if you see, we can also use capsular hooks, which also acts as artificial zonules, thereby providing counter traction and helps in completion of the rexes. So what do we all know that there's a difficulty in capsular rexes in pediatric cataracts because of the increased elasticity of the bag. So what things we have to keep in mind is always use stripe and glue, which decreases the elasticity of the capsule. Secondly, always use visco cohesives. And whenever you are doing the rexes, the maneuvering of the flap should always be centripetal. You should try making a small rexes, and the maneuvering should always be centripetal. So these were few challenges and strategies to prevent an anterior capsular tear.